So I think everybody here knows who I am, but just in case you do not, my name is Antonia. I'm a prelim PGY1. And as Dr. Free said, my presentation is on pancreatitis. And my title is Pancreatitis Play Debate, Clear Liquid or Full Freeze. So I have to say how I came about with this topic. I was rounding with Dr. Bookspan back in December. And we had a young female patient. She was 34 years old. She was admitted for acute pancreatitis. And, she ended up developing necrotizing pancreatitis. She had a short stay in ICU. And when she was feeling better, she was back on floors. And I was like, okay, I'm going to restart her diet and I'm going to start her on clear liquid diets. And Dr. Bookspan was like, why clear liquid diets? Why not just a full diet? I'm like, so we can see if she'll be able to tolerate it and we can advance as tolerated. Anyways, long story short, he thoroughly schooled me on why there is no benefit to starting clear liquid versus full diet. So I told him, I was like, you just gave me the topic for my Mythbusters. So I'm going to try to tackle evidence-based approach to nutritional management in acute pancreatitis. All right, so my first slide, we all know what acute pancreatitis is, but for completion's sake, it is an inflammatory condition of the pancreas that is most often caused by obstruction due to gallstones and secondly to alcohol use. So traditionally, patients were kept NPO, and this is with the belief that pancreatic rest, it reduces inflammation. But as we'll see in the studies I'm going to go over today, they show that early feeding actually helps maintain gut integrity and reduces complications. All right, just going over the pathophysiology a little bit. So acute pancreatitis, it's an inflammatory response that leads to the autodigestion of pancreatic tissue. It causes release of enzymes and cytokines, and that contributes to systemic complications that we see. So like I mentioned before, the traditional rationale is resting or fasting reduces enzyme secretion and allows the pancreas to rest. But as we'll see, evidence and study shows that early nutrition supports intestinal barrier and actually prevents bacterial translocation. Because the studies I'm going to be highlighting, they do kind of distinguish from mild to moderate to severe pancreatitis. I think it's important for me to kind of explain a little bit what differentiates them. So how we classify pancreatitis severity, we tend to use the Revised Atlantic classification. And that defines acute pancreatitis severity based on organ failure and the presence of complications, like development of fluid collections or development of pseudocysts. So in mild cases, there is no organ failure or complications. In moderate or moderately severe, there's transient organ failure that usually resolves in less than 48 hours. And there might be local or systemic complications, like I said, like pseudocysts or necrosis. And then in severe pancreatitis, it's defined by persistent organ failure, usually lasting more than 48 hours. And that can involve respiratory or renal or even cardiovascular systems. So the clear liquid diet, it's more of a stepwise approach. So we usually initiate the patients with water, broth, juice, and we slowly advance to solid intakes. And that's based on the idea that oral intake stimulates pancreatic enzymes. So, we have our main pancreatic enzymes. We have amylase, which breaks down carbs. We have lipase, which digests fats. And we have proteases, which breaks down the proteins. And these enzymes are normally secreted in their inactive form or zymogens, and then they're only activated in the small intestine. But in acute pancreatitis, they are prematurely activated within the pancreas, and that leads to autodigestion and inflammation. So the thought is, if we keep patients NPO as long as possible, or at least start them on a more stepwise diet, like with a clear liquid, that will decrease the chances of autodigestion and inflammation, prolonging pancreatitis. So our first study, this was conducted by Dr. Chebley in 2005. So he studied early oral refeeding in 130 patients with mild acute pancreatitis. And they found that 25% experienced a relapse of abdominal pain, mainly within the first 2 days of refeeding. And it was usually seen in patients that had like higher lipase or a CRP that was greater than 60 on day 4. And then it's also if they had peripancreatic fluid collection was also linked to relapse. But despite this, they did conclude that early refeeding was generally safe, supporting more of a liberal and symptom-guided feeding approach. All right, so the next one was by Dr. Eckerwall in 2007. And I think what's interesting is you'll see that there has been studies as early as the early 2000s showing that there really is no benefit when a clear liquid diet is started versus like a full diet. So in his study, the objective was to evaluate the safety, the efficacy of immediate oral refeeding versus the more traditional fasting in mild acute pancreatitis. So it was a randomized controlled trial with 60 patients, and the intervention was immediate oral refeeding on admission versus traditional fasting with gradual refeeding. And what they found was there was no increase in pain or symptoms or early feeding, and actually there was a reduction in need for IV fluids in the immediate feeding group. That also resulted in shorter hospital stays. So they were able to conclude that early oral refeeding is safe and may actually accelerate recovery in mild acute pancreatitis. So the 2 previous studies I kind of went over, you would notice that they specifically looked at mild acute pancreatitis. And what I found when I was putting this presentation together was that in moderate to severe acute pancreatitis, clinicians still tend to stick with a more traditional approach. So patients are typically not started on full diets right away due to a higher risk of intolerance and complications, such as like ileus or dysfunction. And feeding decisions are more conservative and more tailored individually patient to patient. So we usually have like 2 phases. So the initial phase or during the active illness, oral feeding is usually withheld, which, as I said, due to fear of complications such as pain, nausea, ileus, or organ dysfunction. And then when they do start refeeding, they usually do it enterally, so through tube feeds. And that's usually started within 24 to 72 hours of admission. And then phase 2 is the transition to oral feeding. So once symptoms start to improve and inflammation subsides, they'll begin with like a clear liquid or low-fat diet, depending on what the patient can tolerate. So the next 2 studies are gonna look more specifically into moderate and severe pancreatitis. So the first one, the hunger-based feeding, it looked specifically at moderate to severe pancreatitis, and the diet type was soft or full diet based on hunger cues from the patients. And it was a randomized controlled trial involving patients with moderate to severe pancreatitis. Feeding was initiated based on the patient hunger versus conventional delayed feeding. And the results show that there was significantly reduced fasting time, and there was also an earlier return to diet and shorter hospital stays without increased complications. The second one is an early feeding meta-analysis, and they specifically looked at severe pancreatitis, and the diet type was enteral feeding. So this was like multiple trials on early versus delayed enteral feeding in severe pancreatitis. And feeding was usually initiated within 24 to 48 hours. And they found that led to significantly lower rates of mortality, infected necrosis, and organ failure. So I put this diagram from the early feeding meta-analysis. So the meta-analysis looked at 8 studies containing 727 patients with acute pancreatitis. And then this is like a forest plot that kind of summarizes what they found. So for the severe cases, which is like the top section of the diagram, the pooled odds ratio was 0.53. And for mild to moderate cases, which is the bottom section of the diagram, the odds ratio was 0.55. So both favoring early feeding, but not statistically significant, as you'll notice. But overall, the combined effect does show a trend towards a benefit with an odds ratio of 0.56, with no increased risk, and reinforcing that early feeding is safe across the severity levels.
Was that oral or NG?
They could be either. This is specifically, I think it was oral. Yeah. Okay. And then this is for the hunger-based feeding. So this is a box plot. And basically what they showed was that, well, let me pull it up. Okay. So this box plot visually compares hospital length of stay between patients started on hunger-based oral feeding versus conventional feeding in moderate to severe acute pancreatitis. And what I'm hoping you can see on the image they use is kind of blurry, but is that the median hospital stay is clearly lower in the hunger-based group, and the interquartile range is actually also tighter, which suggests more consistent outcomes. Notably, the conventional feeding group, it shows more outliers, with some patients, staying up to 20 days or more compared to the hunger-based group where the outliers are fewer and lower. So this next study is by Dr. Chowdhury, and it was published in 2022, and it's also a meta-analysis. And this pulled data from randomized controlled trials comparing early full solid diets to more traditional stepwise diets where patients progress from clear liquids to solids. And basically it included a total 1,113 patients across 11 randomized controlled trials. And they compare early feeding, including solid diets, to the later traditional feeding approaches in patients. So the first graph, which kind of summarizes the pain reoccurrence rate by strategy, it basically found that the early solid diet group, they experienced a decreased percentage of pain reoccurrence compared to the early liquid diet and the delayed feeding. And then the feeding tolerance rate by strategy, you can see there's not much of a difference between the two, but actually early solid diet was a little bit more tolerated compared to the other two. Okay, so this literature review by Dr. Myers, published in Nutrition and Clinical Practice in 2023. So this examined recent randomized controlled trials focusing on the timing of solid food introduction in patients with mild to moderate acute pancreatitis. Patients were not completely pain-free when they initiated refeeding, but the review analyzed 4 randomized controlled trials, which was conducted across different countries. And this compared the outcome between patients who received low-fat diet within 24 hours of hospital admission and those who began oral intake within 24 hours. And basically what they found was early low-fat solid diet is safe and well-tolerated among patients with acute pancreatitis. It was associated with shorter hospital stays, reduced healthcare costs and complication rates to the patients. It did not increase like abdominal pain, nausea, vomiting, or refeeding intolerance. And they were basically able to conclude that early oral refeeding with solid food in mild to moderate cases is, it can be done. And then we have this trial, which was done in 2021 called the PATI trial. So it was, this is a multi-center randomized controlled trial conducted in Spain. It involved 131 patients with mild to moderate acute pancreatitis. And it compared the immediate oral refeeding with a low-fat solid diet started right after admission versus conventional approach for, waiting for clinical improvement and progressing slowly through liquids. And basically what they found was that it resulted in shorter hospital stays to the patients. So usually people or patients that were started on a low-fat solid diet, they ended up staying in the hospital 3.4 days compared to the delayed refeeding in patients that stayed 8.8 days in the hospital. They also found that it led to an overall savings of about 1,300 euros per patient. All right, so this slide is just guidelines or recommendations on refeeding in acute pancreatitis. So we have, starting in 2013, the IAP and the AAP guideline that basically emphasizes or places emphasis on clinical signs over lab values, recommending oral feeding once pain improves without needing enzyme normalization. They didn't specifically, specifically specify a diet type, but I think it's an important shift away from kind of like the older, overly cautious approach. And then we have the AGA guideline, which is from 2018, and they recommend early feeding within 24 to 48 hours in mild to moderate acute pancreatitis. And this one did expand on the previous guideline because they included a variety of diet consistencies, including clear liquids, soft foods, or full solids. And then we have the most recent guideline, the ACGA in 2024, and they actually recommend just starting with a low-fat solid diet in mild to moderate pancreatitis. And they show that it actually has a shorter hospital stays and also reduced costs, hospital costs for patients. One of the reasons why I thought this topic was interesting is, even though we have studies dating back as early as, the early 2000s, still there's kind of like this belief that we should do kind of like a stepwise fashion in terms of refeeding in acute pancreatitis. So this survey done in 2021, it looked at real world feeding practices among 178 physicians, and only about a quarter of clinicians, 26%, actually initiated feeding on day one of admission compared to 41% that waited more than 48 hours to start oral intake. And then you'll also see that in terms of the type of diet that clinicians tend to start, 57% actually begin with clear liquids, despite guidelines supporting for early low-fat solid diets. And so I think the main takeaway is that, real-world practice remains, conservative with delayed and liquid first feeding, even though we have, studies that are showing us otherwise. So I think the main takeaway from this presentation, or at least I hope it is that early oral refeeding is safe and effective, and we have concrete evidence that shows this in mild, acute pancreatitis. But so we don't have to necessarily make patients fast or put them on strictly clear liquid diet. Of course, it's always important to follow the guidelines and kind of tailor it patient by patient, see what your patient is able to tolerate. But I think benefits show a shorter hospital stay, fewer complications, and improved outcomes in general.
Anybody have any questions, comments?
Why do you think we're so resistant to change?
I think that we're just nervous. If somebody's admitted for acute pancreatitis, I know in my case, my patient that I had with Dr. Bookspan, she ended up developing necrotizing pancreatitis. So we were scared. She was in ICU. It's just like, what can she handle? We didn't want to do something that was going to give her ileus or cause complications. But Dr. Bookspan was right. So we ended up putting her on a full diet, and she tolerated just fine. We discharged her the next day. So
I think this is a common theme in medicine, that it takes an average of about 10 or more years for practice to change after there's actually really good evidence to change the practice. Even guidelines that are put out, it takes about 10 years. I think we've done studies for physicians that are in practice to change their practice. So people are kind of set on their ways. They learned what they learned whenever they learned it, like where you guys are sitting, and it's really hard to change. And that's part of the reason why we do these Mythbusters. Yep. All right. Let's get this. Somebody else have it?
So just, I guess kind of like summarizing, you come in initially, you made the diagnosis. Was there anything in the study that says how early you can start, like as soon as the first 4 hours after you ruled out complications,
usually, based on what I was able to gather from research, it looks like within 24 hours is usually, the good timeline to start. And also, if they're having symptoms, you can always stop it. You don't force them to continue eating, right? You just kind of tailor it patient by patient.
Keep in mind, a lot of the patients that come in with acute pancreatitis are vomiting.
Yeah.
You can't keep anything down anyway. So think certainly if they're vomiting, you probably don't want to start.
Do you think that adequacy of pain control was equivalent across the studies that were looked at on the meta-analyses?
No, I do not.
Do you wonder about that as a complicating factor?
That's a good question. I didn't look specifically into it, but now thinking about it, I really do. I think, you know, depending on how we're able to treat the pain in patient, that definitely plays a factor in how they're able to tolerate refeeding. That's definitely an interesting thing that is worth looking further into.
Yeah, that's a good point.
Yeah.
I mean, when we were residents, we would not feed anybody until they were pain-free.
Yeah.
And I actually asked her this question when she
You
was,
did?
when she was
Several times.
working on this, because I had the same kind of questions. Well, what about people who have a lot of pain? The one study that she showed that I know of that with the hunger-based pain, when I actually looked at that study, asked her to send me that study, they didn't base it on pain. It was just hunger. And a lot of patients that have pain are hungry. I remember that from when I was treating a lot of these patients. And we would say, no, you can't eat until the pain's gone. You know, and I'm really starving, you know, and we wouldn't feed them. But I guess don't need to wait that long. Yeah. Somebody else had a comment?
I have a question, so, or I guess maybe more of a comment, but I think we see this in our patients frequently where sometimes it requires, in order for them to tolerate like a full diet, more pain medication versus, you know, I think sometimes they'll trial like clear liquid where they're not in significant pain, not requiring more medication. So I think that, like you said, just like tailoring this to the patient, not really forcing them to have like a full diet, because it seems like regardless, having them have a diet, whether it's clear or full, is better than keeping them in PO.
Agreed. Good comment.
Okay, time to vote. Is it a myth? Feeding patients with mild to moderate acute pancreatitis should be delayed at least 48 hours, which was kind of the standard in the past, and initiated with a clear liquid diet, progressing to whole food is tolerated. So is that how many people think this is true? How many think it's plausible? How many think it's a myth? Wow, that's pretty unanimous. Good job. Okay.